The following is a production of Spark Study Club. To see the full video presentation and receive 1 CE credit, please visit sparkstudyclub.com and register for your free account today.
Hello, everyone. It's Adrienne with Spark Study Club, and welcome to this presentation and Q&A titled Removable Implant Overdentures Made Easy with Dr. Lars Bouma. Thank you all for joining us. So before we begin, I have a few important announcements. First, about 1 hour after we've wrapped up here, you'll receive an email to access this course on our site, which includes the recording along with the survey. Please complete the survey to receive your continuing education certificate. If you have any questions, you can reach us by email at support@sparkstudyclub.com or by clicking Contact Us on our website. And next, a special thank you to the sponsor for this webinar, Preet. Their advanced restorative solutions are built upon proven compatibility, precision engineering, and workflow-friendly design, making complex treatment plans easier to execute. For decades, clinicians and dental labs have relied on Preet to deliver predictable outcomes and confident smiles. And lastly, I want to remind everyone to use the Q&A feature in the control panel to ask any questions so they don't get lost in the general chat. And they'll be answered at the end of the session as time permits. Now, please introduce our speaker, Dr. Lars Bouma. Thank you for joining us. He is a board-certified prosthodontist based in Oklahoma City with more than 30 years experience in advanced restorative and implant dentistry. After earning his dental degree from Baylor College of Dentistry, he completed a prosthodontic residency and master's degree at the University of Texas Health Center Science Center at San Antonio while serving in the United States Air Force, where he held several leadership and teaching roles. Today, Dr. Bouma maintains a private prosthodontic practice, teaches at the University of Oklahoma College of Dentistry, and serves on the faculty of the McGarry Implant Institute. A past president of the American College of Prosthodontics, he has lectured nationally and internationally on digital dentistry, implant prosthodontics, and restorative workflows. He is a fellow of the American College of Prosthodontics and diplomat of the American Board of Prosthodontics. That was a lot. A lot in prosthodontics. Thank you so much for joining us, Dr. Bouma. Now I'll turn it over to you to learn more about removable implant overdentures.
All right. Adrienne, thank you very much for the very nice introduction. Good evening, everyone. Let me go ahead and just dive into my presentation, Removable Implant Overdentures Made Easy. I find that a modality of treatment that we can offer our patients that is so easy is not always so easy. So hopefully through the roughly, nearly an hour of presentation that I'll give you, we'll be able to take the highs and lows, the goods, the bads, and the ins and outs of all the processes that we use to put this modality together to make our patients happier, more functional, and have a better quality of life. So let's dive into this. Just a presentation disclaimer real quick is I am being paid by Preet to give this presentation. And I'm also going to show a wide variety of different products by other companies. And so just to say that I'm not one-sided towards one company or another, and thank you for Preet to allow me to do that. So I would ask the question of why and who needs an overdenture? We know that there are tons and millions of dentures out there in society today. So why would someone need an overdenture and who? Well, simply, dentures decrease one's ability to chew by over 60% from an article by Andres et al. The idea that if you have all your teeth removed and you can't function and chew as well as the average person with teeth, that's kind of a horrifying thing. And this changes how someone, socializes, how they chew, the ability to choose wise food choices. There's a lot of things going on with the denture. So if you're going to ask me now who is the proper candidate for an overdenture, well, then I'd tell you almost everyone who wears a denture. So when we look at the process of what happens when we edentulate somebody and we put them in a denture, well, to the far left here, you can see someone that would represent somebody who had all their teeth, had good bone height, good bone quality, a lot of volume to hold a denture in place. That patient at that time might not be the one who wants implant overdentures, but they also are at that point in time with the right implant choice, meaning for me, a bone level implant, not a tissue level implant, would be the ideal patient to possibly put implants in at that time. You also look at people now who would have fixed options for that as well, but there are different reasons why someone wouldn't delve into a fixed option. But as we go to the far right here now, we can see that after years of being edentulated, you lose the bone that would support the teeth that you would have. And if you look at the cartoon again on the left, you could see the root in the bone with the tooth supporting the lip. And if you go to the far right, years into edentulosum, you would see that if those teeth were in the same spot, you would see that the bony base now is completely removed from where the teeth are. And this definitely affects how well that denture fits and functions and is wearable by that patient. So if we can interact and place implants early on, we can slow that process down, making that patient more functional, and happier over the time of their wearing a denture. Let's dive into some facts and figures real quick. These are from the American College of Prosthodontists website. And some of these features or some of these figures actually would say that 15% of the edentulous population has dentures. That's good. Because these patients, and actually it's 90% of edentulous people who actually have dentures, and 15% of those patients are getting dentures made each year. Let me restate that. There are more than 36 million Americans who don't have any teeth, and there are roughly 120 plus million people in the U.S. that are missing at least one tooth and have some form of dentulism. We know that tooth loss happens from decay, gum disease, injury, cancer, wear, and choice. And we know that edentulosum is affecting some of our most vulnerable populations. That's our geriatric patients and our patients who are poor. Oops, let me go back one. And we know that in the geriatric population that the ratio of edentulosum is 2 to 1. That means for every 2 people, at least one of them has some form of edentulosum. 90% of these patients suffer from edentulosum, or 90% of these patients suffering from edentulosum wear dentures. And the number of partially edentulous patients is continuing to rise. And it'll rise from roughly 120 million to over 200 million in the years to come. Consequences of missing teeth can be very traumatic from a standpoint of not being able to function very well in society, to having obesity because of food choices, diabetes because of food choices, coronary artery heart disease, and some forms of cancer. So let's talk about the journey that we're going to go through for the next hour. We're going to discuss real quick mini implant overdentures. And what I mean by that is that I kind of did my own little trial several years ago where I placed a mini implant with conventional implants. And we'll discuss that. A topic that I think everybody's really interested in knowing is, how many implants do you need? What are self-aligning abutments? Because to have an overdenture, you need something to attach to. What are alternatives to self-aligning abutments? Self-aligning abutments in non-normal situations and custom situations. I'm going to present a little bit of what I call show and tell with some reline and some pickup videography, so to speak. Guidelines for simplicity, troubleshooting, common problems and issues that we have. And then in the very end, one of the newest things that we're kind of seeing more of is different coatings that they actually put on some of these self-aligning abutments. And we'll discuss that briefly before we finish. So here we go. So let's just talk about my extraction immediate denture and mini implant protocol. Here's a title slide. It's a research in progress. So let's discuss that. So roughly in 2010, I had kind of an epiphany and a thought that every time I edentulated a patient and took the teeth out, they were kind of miserable for the first 3 months that they were having to wear an immediate denture that was moving around and wasn't very stable. And then I thought, what if I put a mini implant in with the other implants? This is what mini implants were originally designed for in the first place. They weren't originally designed to be the final implant. They were designed to be a temporary mechanism to stabilize things. So what I did over roughly 6 years, I just started finding patients that I was going to place 2 lower implants into, and I decided, what if I put 1 implant right in the middle bony symphysis area between 23 and 24? Over that 6 years, I found that after 35 patients were treated, and I found that two had failures. One of those patients actually lost the implant in between the extraction sockets, and another one lost the implant, what I'd call outside of the protocol. They were already dentulated, they were healed, and but that implant didn't seem to have enough bite into a good quality bone to stay there over time. So let's look at some of these patients. So this is patient number one. Patient number one was already edentulated, already had adequate bone to go ahead and place conventional implants in, but was pretty miserable with the quality and standard of her denture at that time. So, in the course of her treatment, what I did is I elevated flaps in the situation, drilled osteotomies to go ahead and place my implants, and then you can see right here in the very middle of these two lower implants. So let me grab the pointer here. Right here, I used the 1 millimeter mini implant drill, and then I went ahead and took a Panorex just to make sure that I was staying away from the mental foraminas, being clear of the nerve, and making sure that this would be a suitable implant location. This is what the patient looked like directly after implant placement with the dentures back in place. And you can see that the little housing is right around that, over that mini implant, which allowed that denture to stay in place. Later on, this patient was so much happy with the whole situation that she decided to go ahead and have 4 implants placed in the maxilla as well. And I'd say this is probably my go-to favorite way of introducing implants into patients for implant overdentures. Let's talk about patient number 15. And if you look at this patient, you'll see that this is an extremely atrophied patient, has no great tissue quality. If we're going to look at where the attached and non-attached tissues are on this patient, there's not great attached tissue in the anterior. This is actually a patient contrary to have implants placed in the first place. This is not really a great implant candidate. So what can we do to go ahead and provide something for stability on this patient? Some people would say, well, this is a great mini implant candidate. You just drill directly through the tissues into the bone. But this unkeratinized movable tissue is always going to be irritated and the patient's not going to be very happy. So if you elicit a little bit of help from your favorite surgeon, or maybe you have the skill set to do this yourself, if you took, this patient, carefully went ahead and laid a flap in this situation, elevated the tissues out of the way, staying clear of the mental foraminas and residual nerves, you could take some acellular dermis, you could go ahead and place that underneath that tissue, and then go ahead and use a stent to hold all that tissue down. And that way you'd remove the healing process of having a denture or something cause those tissues still to move and never bind down. So in this case, what I did was place 2 conventional implants, 1 mini in the middle, and then I placed acellular dermis underneath that flap and used a stent that I screwed in place that was there for 3 weeks. So the patient did not have a denture for 3 weeks, so they have to consider that. At the end of 3 weeks, we can kind of see a nasty stent in place, but underneath that, you can see that they're starting to create a tissue quality that might be a good tissue quality for that. And actually, from a friend of mine, David Wong, he's told me through this process that if you were to just take a CO2 laser and just lightly remove the mucosa on top of this, you'll get to a keratinized tissue bed underneath this. So we know that there's keratinized tissue underneath all of this. And then also you can see that I pipped this denture to make sure that it's staying clear of where those implants are resting and healing underneath. This is what the patient looks like after 3 months of healing. The mini implant's still in place. The tissue quality is there and it's no longer friable and moving. And what I did then is I took that denture and I used just some medium body PVS in the areas over top of the implants to go ahead and help hold that to place and create a prosthesis that was comfortable for the patient to wear. After I chose what self-aligning abutments I would use, this is what the patient looked like. And again, you can see that tissue quality is much better than what we had to start with. And he ended up being a very, very happy individual through this entire process. Patient number 30. Well, she presented in September of 2015. Again, we did the same thing on her. 2 self-aligning abutments on a denture that is the most difficult denture to do. The single mandibular denture is the most difficult one for a patient to retain, to function with. And so in this case, we were able to return a quality of life and function to her by placing these, in this case, two regular implants and one mini implant in between. And this was a picture I took when she returned after about 6 months. And I went ahead and replaced the inserts on her. And again, I find that I do this roughly every 6 months. And I like this slide because I like to say, don't let the colors fool you, because a lot of us use our assistants to help us in this process. This is a service that my assistants can do for my patients that they are good at. They're wonderful ladies who have great attitudes, and the patients love them, and they're able to get their fingers wet in this and provide something for them. But I tell them, don't let the colors fool you, because the blue ones turn green and the pink ones turn orange and the clear ones turn yellow. And if you look at that, if you look at extended range inserts, we now have red and orange and green extended inserts as well. And so sometimes we need to know what's going on, because I also even find this from referring doctors that sometimes this blue insert will be the wrong insert, and the complaint will be that, well, I put a green insert like what I found in the denture, and the patient can't get it out of their mouth. And we'll discuss that. And that's because the green insert is the highest retention value extended range insert. And so sometimes if the patient doesn't have dexterity for it, they won't be able to get it out. So here you can just simply see I've just popped out the green insert or the old blue insert and replaced it with a new blue insert. Patient number 35. He presented with a maxillary denture and a few remaining mandibular teeth. Just like before, I went ahead and placed his implants. One implant was in an extraction socket, one in healed bone, and that mini implant right down the interseptal bone. And we let him heal 3 months. After we did his extractions and his surgery, we covered him up completely, converted his denture. So here you can see the little mini cap that goes on the mini. And then I use a little bit of jaw relation record material, in this case, blue mousse, that I use just to go ahead and mark where that cap is. And you can see it right here in the middle. And then I cut that part away, and then I pick that up with a little bit of BizGMA acrylic. And the final x-ray is that that patient's going to heal for 3 months before we go ahead and second stage and convert that lower denture. And I'll discuss a little bit more about that also along the way as we discuss when do we reline, how do we reline, things like that. And again, this patient was so happy with the process that he decided to come back for 4 upper implants as well. Again, one of my more favorite ways of introducing implant overdentures for the patients who might not have the money to do more, but have the ability to get this far. So let's talk about the topics of how many implants do we need? Well, it's based on location, quality of bone, whether it's the maxilla or the mandible, how much money the patient has, and, well, you'll see some other things. So performance is one of my first indicators for how many implants a patient might need. So your routine denture patient has a set of dentures that are kind of like flip-flops. They roughly hold to the edentulous bony structures, tissue structures that we have. We glue them in place. We do the best we can do, but they're going to flip and flop around. And so function, dexterity, ability is really, really affected. If we were to simply place maybe 2 mandibular implants, we could turn that lower denture into something more like a loafer, something that now conforms to and fits better to that edentulous mandible and is much more functional. And if the patient has the ability and the bone, I like to say that what does a patient need to be able to get an implant? Well, they need to have health, wealth, and bone. And so we need a healthy client to be able to do surgery on. We need to have a wealthy client that can afford the surgery. And that goes back to our geriatric population who's in fixed income and has problems with things, financially. But then we also need to have that bone. And generally, if someone's healthy and wealthy enough, we can build bone. Or, if they don't don't have the wealth, well, then none of it really matters. So back to performance here. This kind of indicates what I'm thinking. So as I'm asking the patient what they want and what they need, I kind of use these as some ideas for why I'm trying to figure out what they need. So I had a client years ago, financial advisor, came to me, and he ended up getting two maxillary implants and two mandibular implants. He had a lot of plaque, decent ridge, and thick, healthy keratinized tissues, as you can see is outlined right here. And he ended up getting upper and lower implant overdentures with two in the maxilla and two in the mandible. Now, I will say and preface this, I don't like doing two implants in the maxilla. The quality of the bone is not it's not the quality of the bone, the hardness, the resistance to function and wear and tear over time. It's probably not the right way to say it. In the maxilla, the bone is more woven. It doesn't resist the impact to insert and removal as well as the mandible does. And so I prefer four on top, as I showed earlier, and two on the bottom at the very least. And he, came from a situation of where, our typical story we love in dentistry, patients, my daughter's getting married, I need to do something for my smile. And so here we can see that the reason why he got into dentures was obvious. He had a lot of periodontal disease, a lot of breakdown, had honestly fought the good fight for a long time, but this is what he ended up like. So I'd ask you, so how many implants do you need? Well, in the maxilla, I still prefer four, but let me show you a case that is interesting, that wouldn't be according to my protocol, which is also kind of one of the reasons why I've changed from the idea of thinking that maybe two in the maxilla is a good choice. So let's walk through this one. So this is a little elderly lady of mine. She was a really super cute little lady with white hair, and she had posterior bridges, but no anterior teeth. So she was wearing a partial. She had a low vertical, and she just hated her smile. She didn't show any teeth, and her back teeth were exhibiting some problems, had some decay, and were wearing out. So we thought, what if we put you in an implant overdenture? How will this go? And so you can think about a combination of different things going on here. So my question would be placing two implants while doing extractions in the maxilla and putting an immediate denture over top of all that. Is it predictable? Well, let's see. So let's meet one of my saddest outcomes. And like I said, it's formed me over time. So Helen, we extracted her 6 posterior teeth and placed 2 implants. And so here you can see the guide pins from my initial osteotomies and flap placement. You can see that I placed 2 individual implants. One of these is a 3/4 Xive and the other is a 3/8 Xive. So you can see the yellow and the bluish tint going on. So one's a 3.4 diameter and the other's a 3.8 diameter. I made a significant mistake. Yep, I'm agreeing to this. I didn't have her immediate denture. Something happened. Her immediate denture wasn't done the day of her surgery. And so we just rallied together, and my laboratory technician, my removable technician in the back, went ahead and converted her partial into a denture for me while we did surgery that day. He put this together very quickly. It's very nice to have a lab in your practice. But as the saying goes, it fits like socks on a rooster. And after placement of the implants, shortly afterwards, she started dehissing through the tissues. And so this was roughly a month and a half after the implants were placed. And you can see that the tissue quality around the flap, around the facial of the implant wasn't great right here. And you can see that that implant's now probably sticking through the tissue 1 millimeter, and it's probably above the bone, maybe 3 millimeters. Well, I elected to go ahead and say, well, I don't like this outcome. Let's remove this implant and replace it. So I flapped her and looked at what was showing there. And you can see that my 1 millimeter and 3 millimeter amount of bone loss, or 4 millimeters of bone loss, was probably not accurate. And this is probably closer to 5 or 6 millimeters of bone loss. And so we've lost 5 to 6 millimeters of vertical bone height around this implant. Well, I removed that implant, placed another one right back in the socket that we had, and then I let her heal. And I would come back and go ahead and uncover that implant later on. So this is now at 3 months because you can see that I have a heel and abutment on her upper left side. And you can see that she's, granulating in on the upper right side and she's kind of motoring along. 3 months later, we go ahead and put locators, in this case, Zest self-aligning abutments on top of these implants. And you can see that she also has horizontal or vertical bone loss, on number 11 as well. So very similar result that happened on 11 as what we had happen on number 6. And so, I'd say that is it predictable? Not in every case. And so the question would be then, okay, did the failure happen from, the denture or from a material sensitivity, from the patient's health, from the patient having a very stable mandible that, she was a bruxer and a grinder and clenched more. People ask me, why do implants fail or succeed? And I simply use one word: stress. And that can be physiologic stress, that can be external stress, environmental stress, stress from occlusal forces, a lot of different things. Diabetics, smokers, they don't always do really well. So stress can be a really, really bad thing for our implants. So my question is, okay, are placing implants in the maxilla with extraction a predictable situation underneath an immediate denture? And I'd say probably not always a good choice. And spoiler alert, as you can see right here, this case failed entirely. Unfortunately, she lost those 2 implants as well. I've not had a chance to be able to follow up her after this failure. We put her back in a maxillary routine denture or just a regular denture, and she did well, but I don't know why she had failure. Nowadays, I do a lot more material sensitivity testing. Biocomp Labs in Colorado Springs, Colorado, is a source that allows us to have the patient's blood analyzed for material sensitivity. And I have a funny feeling that if I did test this individual, if Miss Helen had a test, we'd probably find that she's probably a part of that less than 0.001% patient that has titanium sensitivity. So this was kind of a learning point for me, but hopefully you can learn from it. How many implants do we need in the mandible? Well, as you see in this patient, we have nice ridge, good keratinized tissue bed. And so I would have told you before, I would place 2. But let's see what happens in this case. Well, being a greedy little munchkin that I was, I went ahead and treatment planned this patient for 4 implants. Is that the right choice? Well, let's see. Okay. I'd say here the implants have been placed. We've gotten 3 months down the road. I've done second stage, and you can see that the healing abutments are in place. The denture has been relieved to fit over top of those, and the patient's happy. Well, what happens over time? Well, over time, you would see that in lower denture over 4 implants, unless they're extended, unless they are placed apart from anterior to posterior with as much functional base extension that you can get, then I'd say it's a bad choice. And here you can see, because of the cantilever and because the teeter-totter effect anterior to posterior, as that every time the patient bites down in the posterior, the anterior lifts up. And over time, you can see that you'll start to get accelerated wear of the self-aligning abutment. So in my opinion, this patient would probably do better by just having 2 implants. Generally, 22, 27, or if there was such a thing, 22 and a half and 26 and a half, a little anterior or medial to where the canines are. So again, how many implants do we need? Well, I'd say it's based on performance, first of all. But as I also said, it's based on location, quality of bone, and whether we're doing it in the maxilla or the mandible. So in my opinion, every patient who has a mandibular denture deserves to have at least 2 implants in the mandible. Cartoon here to your left in your Panorex, you can see that 2 implants in the anterior area, again, maybe just right at the canine lateral incisor area, I think is deserving for everybody who has a lower denture. If we're going to go to implants in the maxilla and the mandible, my favorite go-to, as you've already seen, would be 4 implants on the top, spaced out as far as I can get them, and not at the central incisors and, or central incisors and molar area, but I'd like to have the lateral incisor and, at least first molar area, and then again in the mandible. If the patient has the bone for it, the finances to allow for it, but is maybe not a good candidate for fixed because of hygiene or because of finances, for implants in the maxilla and for in the mandible is a great way to go as well. Okay. And then in this case, I have the patient who was going from having fixed to something that she can't manage. That's kind of an expensive backwards turn in this situation if you look at what it costs to be in fixed and then go to an overdenture. But in this case, this patient has, in my opinion, too many implants to use for an implant overdenture. And what I would do in her case is I'll actually go ahead and sleep some of these implants, or I'll put healing abutments on them and not, add the cost or the mechanical problems with trying to use all 6 implants in the maxilla and all 5 in the mandible. And so here you can see this cartoon has a healing abutment in the premolar areas and here in this 1 molar area. And these 2 implants right here for self-aligning abutments are actually too close to each other to actually use for self-aligning abutments. So I'd always sleep or work over top of one of those. What are self-aligning abutments in the first place? Well, I think for the last 20 years, we've all known that a brand specific was either an ERA or a locator or a ball abutment, a Sika, a Pressy Clicks. These were all different things that allowed us to be able to put some attachment on an implant and then allow that denture to snap to it. So what are self-aligning abutments? Well, they're a type of resilient stud that gets placed on the implant that allows for pivoting of that denture over top of it. If you think about a ball attachment, kind of a perfect idea. The cap or the O-rings over top of it, and just like the ball on the back of your truck, it allows it to pivot and move around it. But for something a little more resilient, we go ahead and use a nylon insert that over a metal abutment that allows for a little more precision and a little more resistance to movement. And so this allows the patient to easily seat that denture and be able to remove it without any kind of problem. How do they work? Well, the insert sits inside the housing. And so if you look at this cartoon here to the right, the insert actually sits on the abutment in a very restrictive intimate process right here. So it's on the abutment, but the housing allows that insert to move underneath the housing a little bit. Okay, so this allows the denture to pivot a little bit, which is ideal because some patients will use their fingers to place their prosthetic. Other people will throw them in like a hamburger and bite them to place, which is my least favorite way of things to happen. But it allows that insert to kind of move a little bit, align onto the abutment, and then click or pop in place. And the advantage of this is because it allows us to have, insert choices, as we'll start to see. What are some of the advantages and disadvantages of self-aligning attachment systems? Well, easier hygiene. Again, I look at some patients that I have when they show up at first, periodontal disease, they've never used a toothbrush in their life. Are they going to be a great fixed candidate? Probably not. And so as you transition them over time, as I'd said, in how many implants do you need, you can take the patient who can be edentulated, have 4 implants placed, and maybe over years, they can transition in responsibility and hygiene etiquette to go ahead and tolerate something fixed. But hygiene is easier. Cost is lower. It allows you to independently service each situation. Again, if a patient ends up losing an implant under a fixed prosthesis, that might affect the ability of that prosthesis to stay in the mouth. But if it's underneath the denture, well, remove it, replace it, add it back to the denture and motor on. It's a great way of things to go. It allows you to provide retention with only 2 implants. It allows you to have a tissue supported or abutment supported prosthesis. Now, I prefer always a tissue supported prosthesis. In my opinion, you make the right denture, properly fitting, fabricated denture with implants that assist its retention. Okay. Disadvantages, well, you might have less stability, but it's still better than a routine denture. and it's it's more sensitive to divergence. And so as we'll see, different implant systems allow for 20, 40, 76 degrees of divergence or convergence on the implants. And so it might be a little more sensitive to wildly placed implants. But let me first say also that they're not all made the same. There are a lot of different companies making their own product. Some of these are implant companies, some of these are manufacturers who actually are making parts for implants. I think at some point in time I had heard that there's like over 500 different possibilities of implant platforms and manufacturers out there. So there's kind of something different made for almost everything. And that can introduce problems for us. I would always say use a reputable implant and use a reputable manufacturer for restoring your implants. Choice is, in my opinion, everything. So some of them don't function properly. Some of them have design flaws. Whether the design flaws in the actual abutment itself or the housing and insert, here you can see different attachments that might be more resilient. So the attachment itself might be not only less pivoting inside the housing so that it's very resilient to the implant. And now as that path of insertion and so insertion and removal of that prosthesis is done routinely, that can affect how well we're wearing on the abutment or the housing. So on the bottom right here, you can see that housing's wore out or that abutment's wore out. And that can be because of, insert and removal. It can be from denture cleansers. It can be from overly resilient inserts. There's a lot of different things. What do you want to replace? $150, $100 abutment or a $10 insert? You decide. I know the patient wants to pay as little as they can. Let's be fair to them. So how do you measure and pick an abutment for your patient? Well, it's simple. Remove the healing abutment and measure the tissue cuff from the top of the tissue to the top of the implant. And in this case, you see 3 millimeters. Well, then I'm going to go ahead and select that 3 millimeter implant abutment. So in this case, as I order this from my manufacturer, I'm going to order a 3 millimeter tall self-aligning abutment. And they're going to add an extra 1.5 millimeters of height to that. So when I measure that from the collar to the top of that abutment, it's going to measure 4.5 millimeters. And as I insert that into the implant, I'm going to see that that's now sticking up above the tissue 1.5 millimeters. And that allows me to properly place a cap or a housing on top of that sits just above my tissue. And that's how you do it. Really, really simple. So what alternatives do we have to self-aligning abutments? Well, there are a lot of different companies that have made different things. And I've talked about balls and pressy clicks and SICAs and ERAs and different things like that. But there are some companies that actually will make self-aligning, abutment solutions for different problems. So we have some stock off-the-shelf solutions, or if you're not drinking, stock off-the-shelf solutions for custom situations. And so in this case, there are a lot of patients that I've seen that are going from distally tilted implants. So in this case, you can see the slide shows an upper arch that was a fixed arch. And there are housings that are made that you can actually screw over top of that. So you can see here that this is a 2-piece housing that offers a collar and a self-aligning insert. Or there are other companies that actually make it all on one piece, and you just go ahead and screw that down onto the MUA, and that can correct your angulation. This isn't perfect angulation correction, but decent enough to go ahead and allow for an overdenture. But there are also now introduced into the market, there are 18-degree self-aligning abutments sold through certain manufacturers that will allow you to correct for a lot of these things. And it doesn't make up for 30 degrees, but if you have a fixed patient with 15, 30-degree angulation, it'll make things better. And so that allows you to be able to take this divergence that you have and correct up to 67 degrees, or excuse me, 76 degrees with extended range inserts. So an 18-degree angled abutment allows for restoration of implants up to 76 degrees. And will get you much, much closer to being offset of 20 and 40 degrees with extended range inserts. Hopefully that makes sense. All right, let's talk about some self-aligning abutments in non-normal situations. So can you put a self-aligning abutment under a partial? Yes, it's one of my more favorite things to do. Why completely edentulate somebody when they're already doing well with their partial denture? Maybe it's designed well enough that I can sneak the implants underneath the distal aspect of it. Or maybe I just need to fabricate an entirely new partial denture that is manufactured for that implant situation. So one of my favorite things to do in class 1, class 2 partials is to put 1 or 2 implants in. And it's nice because I can put a shorter implant in there, either for retention or occlusal resistance. I can put those in as far back as, again, as the anatomy allows, and then I can fabricate them a partial. Looks routine, but functions like a class 3 partial. So that's great. It's almost like having posterior teeth there. And here you can see just 1 pound extended range inserts that allow for that anatomical convergence or divergence. And that's one problem that you do have in the mandible, because as you get further posterior, in the anterior, you're tilted out like this. Then around the premolars, you get more vertical, and in the posterior, you get more, less vertical, more convergent in that bony anatomy. So you need to have something that allows for that. And the new 18-degree abutments now would allow us to go ahead and take this anatomy, correct it a little bit, and be more with one path of insertion through the entire thing. Shows a lot of promise. You can also put self-aligning abutments on bars for those situations, again, where someone might have a lot of implants. We can look at that case that we had the MUAs on earlier. If the space permits, and it should in a fixed situation, we could come back and have a bar made, and then we could put our favorite attachment system on top. So this allows for additional retention for implants that are not in a great alignment to each other. So it gives you good horizontal, vertical, and rotational movements. But you do need a bar that is 4 millimeters wide, at least 3 millimeters tall, and so that the bar can take all of that load. And so these are some examples of how that would be. We used to maybe weld these to cast bars, but now in the CAD/CAM process that we live in today, we can have an extremely well-fitting bar that's designed very nicely, and then just screw these inserts right in place, which allows them to be replaceable over time. So that's great. If you need to service that every 3 or 5 years and replace them, you can do that without having to replace the entire bar. So this is a great go-to situation as well. Custom situations. Well, there are some companies, maybe your lab might have the ability to go ahead and make you some custom CAD/CAM abutments. And this is a company based out of California, True Abutment, that you take a fixture level or implant level impression, you can send that to them, or you can scan this in the digital world that we live in, and they will go ahead and design the abutments to all be in a single path of insertion at the abutment level, and allow for whatever discrepancies you have in implant level. What's nice is that they take your wax try-in and they go ahead and take the cameo of your wax try-in or the cameo of your tissue to the cameo of your prosthesis. So in this case, tissue level to cameo level of prosthesis, and then they can fit that custom abutment in between that area. There's a great example of that. You can see the outline of the denture as it sits on the cast right here, with plenty of room for a housing and abutment. And you can see that the misalignment of that implant, maybe the misadventure of its placement, can be corrected for with a CAD designed abutment that's custom. This is a really neat situation, but there's only one problem with it. Because of the coatings that we can now place on self-aligning abutments, we can resist their erosion and wear over time. And so if you're going to go ahead and have a completely custom situation, well, that's going to mean that you probably have to have these abutments replaced more frequently from a custom situation. But because it's CAD/CAM, someone has a design file somewhere where you could probably just order another one, like if you were to wear out a bar and have to replace it. And then here's another situation where you could have custom situations made and go ahead and screw on your self-aligning abutment interfaces on top of that to replace those too. to counteract what I was just talking about as far as wear out situations. So let's get into a little bit of show and tell. So instead of me talking, which I'll still be doing, I'll show you some of my more favorite things. So I have a patient who, needed to have a reline. So we had literally placed her implants roughly a year and a half ago, and she went through a 3-month healing process. We converted her immediate denture to a implant overdenture. And roughly a year later, she was complaining about a lot of space underneath that denture, a lot of movement in that denture. And I sat there and said, well, Mary, I'm sorry, maybe we need to go ahead and realign your denture again. And again, had I prefaced that all up front with the entire process, here's a brand new car, but you still need tires and oil changes and washers, and different things like that. When you present it that way to your patients, they then expect that when something happens in the future, then that they have to deal with it. We were all taught and told in dental school that someone needs to heal 5 years, 6 years before their edentulous bony base will stop resorbing. And from studies without Angie Talgren, we've seen that in the first year, you'll start to see a lot of resorption. If that patient has a lot of resorption, they'll probably continue to resorb at a high rate. If they have slow resorption, they'll actually resorb at a slower rate. We'll also see that implant overdentures do better than non-implant retained overdentures because of the force and strain to that bone resisting that denture under occlusal forces. And we know that the implants don't retain the bone, but they do slow down the resorption over time. And so we then look at what are we going to do for these patients as they need servicing along the way. So in a sense, you can basically say, well, here's one of the oil changes that you need in your denture, Mary. So we've taken her denture, we've gone ahead and disinfected it in bleach and tartar and stain removal. And so the denture's, coated with calculus and all kinds of stuff. And so we cleaned it all up for her, first of all, before we work on it, and also to protect our laboratory technicians from having gross and grody things as they come into the lab. And then, as I'm going to show you, my favorite way to remove an insert is just to use a number 2 round burr. And so here's my lab handpiece and a number 2 round burr. And I'll just go ahead and circumferentially go around that housing until it pops out. There's one out, and then I'll remove the other one. And then I'll tell you, don't be cheap. The insert kits aren't that expensive. Just throw those away and start with a new set when you're picking those up. And then in this case, because that area right around that housing needs to be deepened and made wider. And so I'll go ahead and use some pear-shaped burrs there to go ahead and remove the excess material. And then I have a denture ready for impression, so in the mouth. Now, when I'm going to do this procedure, I'm generally going to start with the least retentive prosthesis first. So in this case, the maxillary denture is more stable than the mandibular denture as we're doing a reline procedure. So I will place the maxillary denture back in her mouth. In this case, I did upper and lower impressions on her, or relines. And so I started with the lower. And so I put the upper in place and then worked with the lower. And so here you can see that the reasons for the reline, again, was the patient had been in dentures for a little over a year, but she had a lot of remodeling and bone loss. And so you can see around that implant, you can see that now there's poor keratinized tissue, a little bit of irritation, and bone loss. And so it's not ideal that when we started was just 1.5 millimeters above the tissue, had good tissue quality around it, but this is what happens over time. So just a reminder, every time that I see somebody, or not every time, but at least once a year, I'm going to go back and make sure that their abutments are tight. And also want to make sure that when I insert their abutments in the very first place, that I'm going to go ahead and torque them to the implant specific manufacturer's recommendation for torque tightness. So at least 30 to 35 Newton centimeters, but some implant companies will tell you less. So just go back to your manufacturer. And then I want to discuss real quick, okay, the impression process of doing this. So this is going to be of course, an intraoral impression with PVS, but the technique is the same whether you're doing a reline or whether you're doing an impression for a brand new denture. For me, my favorite way of doing this is I have the patient the with the implant placed in the jawbone, with the abutment properly positioned above the tissue. In this cartoon, this abutment's too tall. I would love it to be a little bit lower. But this also kind of signifies what's going on with Mary. And then I'm going to pick the impression coping of choice here. If I'm going to make a brand new impression for a new denture, I might use an impression coping. I might use a processing spacer. This isn't necessarily for intraoral impressions. This is based more for the laboratory to make sure there's adequate room for your housing later on, but you can use it intraorally, okay? Or you can use an insert housing, okay? And as you see from the cartoon here on the top, an impression coping would then allow me to pour a model that has an analog in it. Now, good thing and a bad thing for that, though, is that now that I have an analog, I'm going to more than likely process my housing into my denture. One of my least favorite things to do, because when I do that, gotta move my mouse, excuse me, is that when that is processed in the denture, then it doesn't allow for tissue compression. So in most cases, especially over 2 implants or even over 4, that denture is now going to be implant supported, okay, more than tissue supported. So when you pick these up in the mouth, it allows for compression of tissues, and now you have a implant assisted denture instead of an implant supported denture. So that's the reason why I don't like to process my inserts in the lab, except in the situation of a partial denture, because the anterior portion of that partial denture won't move. I don't want the inserts to move either. And so I'll process those in the lab. Now, in most cases, and what you'll see here now, I'll put an insert housing on top of that self-aligning abutment, and I'll pour a model into that. Now, the model will have, a representation of what that insert looks like. This allows me to have a denture made where my technician now knows what constraints he has for, tooth position. He might have to, if there's nothing there to represent what's going to take up space, then if the tooth and the insert are going to basically be in the same place, well, you might grind a hole in that denture later on to pick up the insert, and that's not a good situation. So my most favorite way of doing things is making an impression with an insert so that the stone cast, can represent what it would look like in the patient's mouth prior to having things done. And again, you can do that with a processing spacer or an insert. And so we'll see. So in this case, I've taken, again, the inserts, I've just placed them on self-aligning abutments. Again, just to point out, you can see that we've had bone loss and now a little less than ideal tissue quality. This is going to be a more ideal case to send to my buddy David Wong and let David go ahead and do a keratinized tissue graft around that, so that Mary can have a better quality of tissue there. And then I'm going to make sure that I do the appropriate adhesive. Okay, there are different adhesives. There are spray adhesives, there are PVS adhesives, there are alginate adhesives. Make sure that your staff has the right one. Make sure that you're using the right one. We'll put that not only on the intaglio of the denture, but also roughly over to the outside 4 or 5 millimeters, so that when the impression material laps over, it's attached to the denture, not wanting to fall off. I'll fill the denture appropriately, and then I'll place it in the mouth. I'll border mold, so I'll grab that patient, I'll have the patient bite down, I'll grab their tissues, I'll move their tissues back and forth, move them up and down in the anterior, hold my fingers on top of the denture, have them stick their tongue out, left, right, make sure that I'm doing this border molding movement. As I've made the impression in the first place in the denture, I've taken a little bit of PVS and I put it on my glove so I can check to see what my setup is doing. When that material is a little less gooey and wet, and a little more resilient to touch, then I'll come out of the mouth, I'll quit border molding and just let the patient sit there for the required amount of time that impression material has to set. For me, I pretty much set everything up on my Apple Watch for 5 minutes. I disappear and I come back in and go ahead and remove the impression. And here you can see that the impression's made, and you can see that the PVS is lapped over top of the housing a little bit, and we'll have to trim that away. And we'll see that here in the next couple impressions. So here's the impression when it comes out of the mouth, and we'll trim up all the excess before it gets sent to our laboratory technician. And then internally, I'm going to go ahead and trim around the outside of the insert in the housing on both sides. You can see here's the insert. So this is all covered with tissue or with a PVS, excuse me. And here you can see that as that's trimmed away, we have that little bit of PVS that's going to come out. I like to do this. I don't want my technician doing this because I get the final say on what's going to happen in this situation. And then this is what it would look like when it's finally trimmed up. And then a stone cast that will get poured into that will have a cross section that looks like this. Now I'm also going to look at this. I'm going to shine some light up underneath my denture to make sure where I'm thin. So this is where that recess for the housing would be. So I'm going to go ahead and mark that. I'm going to take a Sharpie marker and I'm going to mark that so that we can see that my technician now knows that he needs to wax that up a little bit more, make the papilla thicker, and so that we have some area to resist breakage, show through, potential grind through as we're picking that up. And then I send it to the lab. Now, my technician likes to flask everything. He'll do a heat cured process. And so in this case, you can see that every time you make an impression, if you don't remove enough material out of the inside of the denture, it'll kind of lock in with the impression and it can break. And so then we'll gently pull that out. My technician also knows that I don't want him doing this. I'll go ahead and I'll sacrifice the impression, do whatever I can to gently get that piece out and insert it back onto my model. And so to prevent this, I take a pear-shaped burr and I go ahead and just gently grind the internal aspect of the impression. I roll over the edge. As we know from crown preparations, anything that comes to a 90-degree or acute angle has a potential of fracturing, and that's what happened in this situation. And so I'll do that, blow that off, and send it to the lab. And then I also am very critical about how I glue things back. So I'll dry fit this and put a little bit of cyanoacrylate or super glue around the edge and let that glue in place. And then I also know that if there's something else missing, I know what I'm gonna have to deal with at insert later on. So here's the denture back from the lab, ready for the adjustments that are gonna have to be made. And so we can pick up the housings in the patient's mouth. So this is the impression process of what do we do, whether we're doing a reline, upper or lower, doesn't matter. Whether we're doing final impressions for a new prosthesis, upper or lower, doesn't matter. Same process. Pick your housing, make sure you're using proper materials, proper times, taking your time to do things right. We know that when things are done well, you can do them once instead of hopefully doing them more than once when you're not doing them well. So let's now go through the step-by-step chair side aspect of picking up housings. And again, I'm going to specify, I would rather pick them up chair side than have them processed in a lab. I would almost probably say that 95% of the time that of the cases that I've had processed in a lab, I've had to cut out the inserts and repick them back up in the mouth anyway. So why have a higher lab fee? Why go through the frustration when I can just go ahead and save the time and do it at pickup? So I schedule these patients for a half an hour in the morning for impressions and 45 minutes in the afternoon or next day for picking up of the inserts. And that's what I do. So in this situation, we have William. And William's had 4 implants placed in the mandible. He is somebody who actually has maxillary complementary of teeth. He is a wear patient. He's a bruxer. He's going to be fun as we watch him, moving along years into the future. He's not financially able to do a fixed situation, so we did an overdenture. And then we're going to see how well this works over time. So we'll see whether he is a higher degree of breakage or wear, things like that as we go along, because that's what should happen in somebody who's a wear patient already. Although what he can do, though, is remove that lower denture for at least half his life, because he won't be wearing them to bed, because that's also my other protocol. Dentures need to come out for at least 8 hours a day. And so let's see what's going on with William. So in his situation, at the time that we put our inserts in, the inserts are either a millimeter or, the attachments, the self-aligning abutments, are either a millimeter too short or a millimeter too long. He doesn't have a whole lot of room in his denture to allow for a millimeter too long. So in this case, I went ahead and removed a little bit of tissue off the top to go ahead and tug those abutments back down into the tissue a little bit. Now, just a reminder, when you put the housings in place, you need to put blockout shims around those. And so we have O-ring or blockout shims, or in a situation like with Mary earlier, this bottom right slide is actually her. And I didn't put a shim there because of the facial tissue loss that she had. I used a little bit of Cool Dam by Pulp Dent to go ahead and block that out so that I wouldn't lock onto her when I'm actually doing the attachment process. The other consideration is that you will have patients who've had these for a long time, and the abutments will look long in their mouth. And you can use more than one shim. There's no law that says you can't use 10 shims, 5 shims, 2 shims. So be cognizant of that before you lock a denture into the mouth. That's a miserable day when you do that for you and especially for your patient. So the O-rings and the blockhead shims are in place, and you can see how there's adequate space around his tissue, maybe less than ideal right here. And again, as I'm going to talk about troubleshooting later on, I want you to kind of think about this. This is going to self-align very well. It's directly equal to the tissue and exactly where it needs to be. This might be slightly underneath that. And so William might not be able to fill this click in as well. And so we'll see what happens. So the denture, as it's come back from the lab, is ready for insert, but you'll see that the insert housings are already the exact same size as the recess that we had for the housing in the first place. So you can see the intimacy of the housing right here. So what I do is I disclose using a very expensive Sharpie marker. I go ahead and color inside the concavity that I have for each insert. And then I use a handpiece to go ahead and drill that out. And so I allow for at least a millimeter and a half of circumferential removal of that extra acrylic. I also allow for an extra 2 millimeters or 3 millimeters of occlusal vertical depth so that housing can sit into that denture when the patient bites down on the denture. And I like to block that. I like to use the Sharpie so that I know that I'm removing universally all the way around that. I also like to take that denture and I will hold the denture one way and then I'll remount it a little bit and then I'll hold it another way and remount it a little bit. That way I'm not favoring one side or the other. And then here you can see that I have just an analog with an old self-aligning abutment that I use to check to make sure there's space right there around that. And you can also just take a self-aligning abutment analog and put a housing on top of that and use that as your tool to make sure that you have space. Come here, you. Well, the laser wants to stay there. And then I'll make sure that I go ahead and put a diatoric inside the hole. So you can see here with a number 2 round burr or number 4 round burr, I can go ahead and cut a little ledge inside the inside of that concavity. And this little cartoon kind of represents that. You can see the space required for the housing with the excess space around it, the little bit of diatoric around it that allows me to go ahead and have whatever material I'm using to get picked up in there. And just another little pro tip here real quick is if you're unsure how much material you need to use to do your pickup, you can take a little bit of fast set, low viscosity impression material, in this case, just Aquasil fast set PVS that I used, and I can fill in the concavity and say, if this is how much acrylic I'm gonna put in here, then I can actually see in living color where it's going to express to. And I'll see that, well, it's way too much acrylic that I'm going to use. I might lock onto that abutment and not get the denture out, different things like that. So want to be able to consider that. You can also cut this in half, look at it through the light, and you can see where you need to adjust the denture more to get it properly inserted. Then I like to coat the inside of the denture. I was originally taught, doing this, I was taught to go ahead and put Vaseline on the inside of the denture, but I found that didn't always prevent whatever pickup material that I was using to stick to the denture. And so I've used a little rubber sep. First of all, I want to make sure that my patient's not latex sensitive, but they also have nitrile rubber sep that you can use as well. And you can, coat the denture, let it sit for about 5 minutes, and this will go ahead and give you a barrier that will prevent the material from sticking to your denture. And we've all seen these dentures that have excess acrylic on the inside. They weren't properly seated in the first place, so there's excess material. Someone put too much into the retented concavity, and had a problem with that. So this is what I like to do. And then I go to whatever material of choice that I want to pick up. So for years, I used a temporary material for making temporary crowns. You could use that. It's a Biz GMA. It doesn't bond to the denture. It's white. If you ever had a situation where the denture might be too thin, you could do that. It's readily available in your practice. So if you don't have anything else, you can use acrylic, denture acrylic. This is denture repair acrylic. This is a newer material that I'm starting to use called Stellar acrylic resin. It's an auto cure, light cure material that makes things very fast. Back in the day, I was using MucoHard as well. And this was just a chairside reline material. I don't like to do chairside relines on patients. I have all my relines processed in the lab, to just let that be known. But with acrylic, I did acrylic for years because it would adhere to the denture. But the problem is that you might spend 5 or 10 minutes with the patient biting in place while this material is setting up in their mouth. Especially in the colder months, it might take longer for that acrylic to set up. So you let it cure in the mouth a proper amount of time, and when you remove it, you can see that the extra little bit of acrylic, in this case, is sitting on top of that barrier, not sticking to that denture. And then we'll go through and we'll clean up the barrier material, and then we can go ahead and scrape off the excess acrylic. And again, it might not be readily viewable, but it's right here. There's some overflow of excess right here. That's just kind of seeped out. I clean it up with a pear-shaped burr. And now you can see that this is very nicely cleaned up. There's no excess material, just the housing sitting in the denture, exactly how we want to see it. And then we can look at now what the abutments look like in the mouth. And going back to that first day of where I lasered him, you can see that this tissue's retracted back some. So we have nicely positioned abutments there. And then I will do a 1 week or 24-hour and 1 week recall. And during that time that they're in that recall, I leave them in the black inserts that are used for the housings on pickup. And I allow them, in a sense, to kind of use those as training wheels. And then a week later, I'll go ahead, or a month later, I'll change out those black inserts based on the patient's dexterity and ability to do things. And then I'll go ahead and change those out with the proper insert. And generally, I've always kind of started out with blue ones, 1.5 pound inserts. So let's talk about some guidelines for simplicity here. And I'm going a little bit long, maybe, I don't know. So we'll have to kind of finish some things up here real quick. So for some simplicity guidelines, you have to select what right inserts you might have for you. And these would be what I call unique inserts or extended range, or inserts that have males in them. And that allows for more dexterity, a little more resilient retention of the denture. And you find different ways of using them in different ways for different reasons. So if you have a patient who's had an overdenture before and their dexterity is great, and in my cases, I'll start them out with blue inserts. But if the patient's struggling in the mouth to do things, then maybe I'll go ahead and put them in a red or orange extended range insert. And if you have a patient who's a seasoned patient who's been doing this for a long time, who might have occlusal stresses, William will eventually maybe go to pink inserts because he's going to need something more resistant to the stress and strain that he's going to put in. If you have someone who, again, is struggling and never has had an implant overdenture, then maybe go ahead and start them out with the red. In some cases, they're not very retentive. They don't resist off-axis, biting and loading very well. But it's a nice place to start. And then when you buy these sets, you can buy these sets with, the 1 pound, the 2 pound, and a 4 pound insert. And so just leave that in the patient's case pan and you can insert it later on. So maintenance, again, this is something that you need to think about when you're discussing the case from the very beginning. Inserts need to be replaced, according to Mackey, every 12 to 18 months, and this is wear dependent. I put my patients on a 6-month recare program so that a lot of times I'm replacing those inserts at 6 months. The other thing that I find is that Around 6 months, sometimes a year, the patient will start complaining about sores and the denture moving. And I equate this to having a tennis shoe with no lace in it. If you're running around in a tennis shoe that's loose on your foot, you're going to get a blister. Same thing with a denture that's loose in your mouth. You're going to get an ulcer. Housings need to be replaced every 3 years. And what you'll find is after a while, your inserts won't stay in your housings anymore. And so if you're more proactive with a recare program that just allows that patient to be appointed for a 45-minute appointment where you're removing them, grabbing new ones, and replacing them, you're going to have less problems with that patient over time. Abutments might wear out in 3, 5, and maybe in the future we'll see a longer time that they're not wearing out themselves, and we'll see that. Patients still need cleanings. I tell patients, you just spent $2,500 for a single implant. That's an expensive process. It doesn't mean it doesn't need to be cleaned. You need to buy an electric rotary toothbrush, and you need to see the hygienist for proper recare. And then relines need to be done as needed, 2, 3, 5 years. Patients need to know that. And a line that I didn't put in here or is not in here is that dentures also need to be remade when they wear out. And that might be 3, 5, 10 years. You never know. If you're having problems with housings, how do you remove them? Well, there are some people who will tell you that if you can take a hot probe, you can melt the housing, as you're seeing here on the top left, introduce that heat into the housing, which will melt the acrylic and the housing will pop out. You can also use a 1364 Allen wrench that you can heat up under a flame and go ahead and stick it into the housing. That will melt the acrylic and then it'll bend out. You can use my favorite, the number 2 round burr that will go ahead and remove it. And Zest even makes a trephine. What I would tell you is what works every time is a round burr, and it's efficient. So again, that's my favorite thing to do. Let's talk really quickly about the self-aligning tool that we use for abutment placement. So we use it to place the abutment, to place the inserts, to remove the inserts, all these things. It's a necessary tool for this entire process. So here you can see it being made with this little peak attachment neck around it. So you can see it's holding on to the abutment. We can then screw that in place. And then we can also use a 1.25 millimeter hex driver down through the inside of this with a torque wrench to torque it if we want to. Here you can see the other ends of that same tool being used to remove a insert, or in this case, a black insert, and then placing another insert on the other side. And just another pro tip or reminder is that, when you're placing these, hold the denture in your hand. Don't put it on the countertop. I have a 4-foot tall assistant. She's mighty, but small. And, sometimes she might just go ahead and get all 65 pounds of herself up on the countertop to push an insert into a denture. And if she does that, she can break that denture in half. So we need to be really careful with that. Try to make sure you do it in your hand and tell your staff if they're having a problem with it, bring it to you. It's always worth taking the time than it is replacing the denture. All right, troubleshooting some common problems. So what happens when the inserts keep popping out of the housings? Well, what's going on? Well, you can have a path of insertion problem. So if you have 2 implants that are too divergent from each other, you might be able to get that denture to click in on one side, but it'll actually pull the housing out on the other side. I also, had a patient who liked to roll his denture out from the very back. He'd roll it over like how do you get a cap off a beer bottle? You can't just come straight up with it. You got to go over the side with it. Well, every time he'd do that, he'd pop out the inserts every time. So I kept on telling him, use your fingers here in the interior, lift it up, but he wouldn't do that. If you have implants that are too divergent, you can also consider the idea of changing the abutment out. And in some extreme cases, you can change out the abutment and use an extended range insert or a combination thereof. What if you made a brand new denture and even with the strongest insert, it won't stay in place? What's the problem? Well, as you can see here, surrounding these abutments, you can see that they're underneath the tissue. So again, proper abutment selection is important. And when you have an implant where the tissue is higher in this case, the palatal than the facial, you need to select that abutment based on the palatal, or you need to surgically remove some tissue so that you make that equal all the way around. Again, we also talked about the fact that the implants are too divergent or convergent. That can affect how well your denture is going to stay in place, even with the strongest inserts. And the other thing is that properly fit and disclose your denture before you actually try to pick it up. This takes a second. Disclose it, adjust it, clean it up really well with alcohol to get rid of all that disclosing medium, and then go ahead and do your pickup. What if you have no retention on old prosthesis? Well, that can be a combination of things. In this case, you can see this gentleman doesn't really brush his teeth very well, doesn't brush his implants very well. And so we have a little bit of a challenge there. There could be food debris inside the actual aligning abutment itself. And so it can be food debris and it can be a blue, a pink, a clear insert. These are the ones that have the male component internally. And the male component won't be able to get into the abutment. And so it'll resist it from actually, clipping in place. And so we have worn inserts, we have worn out abutments, we might even have worn out housings. Lack of mucosal support and maybe needing a reline. Again, when that denture is moving back and forth a lot, it's time for a reline. Do these things wear out? They definitely do. Okay. And I first started figuring this out around the 5-year mark, but there might be some things that'll help us out in the future. So what do we do when we have worn out abutments? As I'm talking with that previous slide, is that this can be related to a lot of different factors as well. The abutments can be a faulty design. The inserts can be worn where the denture prosthesis is moving a lot. You can have someone who's a grinder and a clincher, and again, they're walking that denture back and forth, up and down. The abutment height discrepancies where the denture is not very stable, but it can also be environmental. It can be, I live in Oklahoma with a lot of dirt roads, a lot of dusty situations where people wear out not only their teeth, their dentures, and their abutments as well, but denture cleansers themselves. Sodium bicarb is actually something that can be abrasive. We actually strip paint off of cars with it. So if your patient is soaking your denture in a fizzy cleanser at night with the intaglio side up, that sodium bicarb is actually staying inside the housing, allowing it to be more abrasive every time it's clicked down onto that self-aligning abutment. And an article, a little research study done by Carolyn Wen some years ago, she actually found that different things can actually affect not only how the inserts are affected inside your denture, but also how they can accelerate the wear on the abutment and different things like that. One thing that I found was actually pretty interesting was that she said that Listerine, Cool Mint Listerine mouthwash, actually hardened your inserts. I actually need to talk to her about that because I think it's a pretty interesting finding. So one last thing about troubleshooting. What do I do when I have a denture repair? On this case, lower denture is fractured. And sometimes I see this happen because the denture now became high centered on the abutment. Do I do frameworks in all my dentures? No, I don't. I actually start out with a routine denture more than I do with frameworks in all of them. So I add frameworks normally later on or when I know there's going to be a problem. William might be one of these people who's going to go ahead and show me that this should have been done first. All right. So the last 2 slides is what are the differences in coatings on self-aligning abutments? Well, this is a very busy slide. And we don't need to worry about all this kind of stuff. There's a whole lot of stuff going on here. But each coating, as you see referenced on the bottom here by self-aligning abutments that are available in the market today, whether it's gold, whether it's champagne colored, whether it's pink, or whether it's going to be rose gold, this is a future product. These all provide benefits that we're going to have with these abutments. And so is there a perfect coating? Not necessarily. The gold nitride or titanium nitride coating, the gold one that's been on our self-aligning abutments for years, has proven that it does really, really well. It works great on drill bits, it works great on abutments. But we've had improvements with breakdown of those over time. We found that if we were going to go ahead and use a titanium carbon nitride, that is the pinker coating, that would work out even better. But in my opinion, there's a little bit of an anatomical problem with that abutment that I don't necessarily like. And when I think about now, zirconium nitride, which is something that's available now in the market, is an improvement on at least the titanium or gold nitride on a legacy design. And I think this is going to be something that we're really going to see great retention and longevity situations for. And I know one company in particular who's going to go ahead and change that to a zirconium carbon nitride coating, which will actually be even more resistant. So hopefully in the future, we'll have 10-year abutments or so. We'll see what happens with those, but they should be much more resistant to wear. They're more lubricating. They're just going to show that they're going to be a better product. So I lied. One more slide. So in conclusion, just replacing, inserts to stronger inserts isn't always going to fix your problem. Make sure you're diagnosing needs for reline, needs for proper pickup of housings, abutment replacement, things like that. Pay attention to your patient's denture cleaning habits. The patients we have the biggest problems with are the ones who are cleaning their mouth. It doesn't matter what they have, teeth or dentures, same problem. Do your periodic checks. More denture patients don't come back to their dentist once they get their dentures. They don't think they need you anymore. But as I remind them, you don't have the same implants that you were born with. You now have you have a very expensive tooth now, or vice versa of that. And so implants aren't cheap, so take care of them along the way. Most retention issues, they have to do with bad chair side, techniques. So don't put this off to your auxiliary. Do it well, do it right. Make sure you're reducing the inside of the denture. Take an extra 3 minutes so that you don't have to do it all over again. And then schedule your patients for recare. Stress the importance of them coming back at 6-month intervals. It's good for your practice. It's good for them. And with that, do I have any questions?
Okay. Thank you so much for that presentation. This is the time. Thank you so much. This is very insightful. This is where we have the opportunity for questions to come in. I'd like to remind everyone to use the Q&A feature in the control panel on your screen to ask any questions. So I'm going to get started by one question is, where can I buy abutments with the ZRN coating?
So that newer coating that I was talking about that is now, introduced is being introduced into the market. My go-to source for my self-aligning abutments would be Preet. And so if you go to Preet.com, you can definitely download their catalog and you'll be able to hopefully be able to pick out an abutment that works with your specific implant design. And if you have any other questions or any other problems, whether it would be, identifying, implants or different problem situations, if you're not really aware of problems, they can help you with that as well.
Okay, here's one. How are you promoting removable implant overdentures at your practice?
Well, I go back and I talk with every one of my patients when we are discussing the very first appointment, whether they have teeth that are failing and we're going to put them into an immediate denture or whether they're in a denture already. I always give them the option to update their performance that they're already functioning with. Many patients are sent to me in the first case because I place implants, I restore dentures. It's my specialty. It's what I've been trained to do. And so I'm always discussing performance and how to make their situation better. And so it's about discussing that and also listening to your patient's desires and seeing how you can introduce something better for them.
Right. Okay. What cases would you say All-in-X is absolutely counterindicated and a removable solution is better suited?
Well, I'd say that in the market today, All-on-X is being pushed way too much. The problems that we have yet to really see in the mass market push of All-on-X is we're going to see these failures. But when I'm starting with this patients, I can go back to one case that I was showing earlier. The gentleman, like I said, wasn't brushing his teeth to start with. He came in and said, I want to go ahead and do All-on-X. And we discussed cost. And he's like, that's a lot of money. And I'm like, it's a lot of money for someone who's not going to take care of it. And his wife sat in the corner and she said, well, honey, maybe this is a good place to start. And so I would say hygiene, finance, bone. These are all things that don't work well for all on X. There are patients who just don't have the posterior bone to do it. I think starting out a patient with zygomatics is a lot to do right out the gate. I like to consider that for ladder treatment in case someone has failures and problems down the road. So I still think that a majority of the cases that I have in my office are still done with overdentures, and they work really well. These patients are very happy and are very serviceable, as I talked about the advantages and disadvantages.
Right. And that kind of leads in with this question asking about the perception that removables are less quality restoration when compared to the fixed full arch. How do you overcome that perception?
I'm not always so eloquent with my words, and there's always a better choice of how you sell something for somebody. But when you can equate, in a sense, a fixed solution in a removable manner, you can discuss with your patients a situation where you can have the exact same function at a fraction of the cost, and it looks somewhat identical. I mean, I can cut back denture flanges so where I won't have fullness of face. I have patients where I didn't show a series of slides where if a patient's already edentulated, they need some fullness. If you put them in fixed, then they don't have the same look. Sometimes it's about aesthetically how they're going to look at the end of the procedure, and sometimes it's about just trying to sell the function aspect to them. I don't like to use the word sell, but I can definitely relate that a denture that is going to be just as stable and functional as a fixed situation with a lot less problems.
Right. Okay. And going for when would you go for the 4 versus the 2 on the mandible as far as implants?
So again, as I was saying earlier, that patient who's been a long time edentulous in the mandible in the posterior, they'll have resorption. They have no room above the nerve. They're not a candidate for 4 implants. So it comes down to health, wealth, and bone. If they have the ability to pay for 2 extra implants, they have the bone available for those 2 extra implants, then they can have that functionality of a very stable mandibular denture. The other thing is, in back, if you can think about William has 4 lower implants against a natural dentition. He's now going to have a denture that is very stable in the mandible. And as he wears it out and causes all kinds of issues to it, he's going to be a Mack truck on that thing. It's going to be easy to replace, easy to function with, easy to service. And so for him, 4 was the natural choice. For some of my initial patients, again, that had no bone in the posterior and have been long-standing, like that partial denture case that I showed with just 6 anterior teeth, when you edentulate those remaining 6 teeth, that might be a better situation for just 2 implants, even though that case showed 2 implants in the back too. That patient will now be that patient who can have 4.
Wait, so we conclude like the CE part of this webinar. Which overdenture system do you recommend?
My newest overdenture system that I recommend, because of versatility, because of coating, because of now an angulation change that allows us to correct, to 18 degrees and 76 degrees of abutment correlation or correction is Preet-Lock. And again, I was happily introduced to the owner of Preet decades ago, and then his son, got into that, and now Young Innovations owns it. It's always been represented by great people who are very knowledgeable and very helpful, and it's always great to have either somebody by text or by email that can be helpful. And I'm not unique. They're going to help anybody who needs help. And so one of my favorite companies, and they have a great product and they have a great follow-up. And so that's who I go to first.
Good. I love that. Okay. Well, thank you everyone for your questions. We've run out of time. So if we did not get to your question, we will get to it after the webinar via email. So in about an hour, we're going to send a link to access the course, and it's going to include the recording along with a survey. So make sure you complete the survey, get your CE certificate. And that concludes the webinar for tonight. Thank you, Dr. Buma, for this educational presentation, and also Preet, and be well.
You're very welcome.
We're good.
Thank you.
We hope
Hello,
you enjoyed
everyone.
this
It's
presentation
Adrienne
of
with
Spark Study Club.
and welcome to
You
this
can receive
presentation and
CE credit
Q&A
for this
titled
lecture
Removable
by visiting
Implant Overdentures Made Easy
sparkstudyclub.com.
with Dr.
Thanks again
Lars
for
Buma.
listening, and we hope
Thank
to
you
see
all
you
for
again
joining
soon.
us. So before